Welcome back to Diabetic with Us. This is Dr. G. Today's episode isn't just clinical, and although I know I've been gone for a few days, just resting up, but it's about the system of healthcare. So I think everybody knows the shows Love is Blind and Age Difference, and I found it very interesting that they're trying to approach things blindly, right? They're trying to see if people date each other or like each other without the visuals, correct? And I wonder if they could do that in medicine, like not seeing the patient's health insurance to see if they're covered or not. They should do like, is medicine is blind, right? Is medicine blind, right? So they can have same patients, the same thing. Everybody has the same thing. They just don't know the race. They don't know the patient's insurance status. They don't know the patient's what else? What else? Demographic, like where they from and everything like that. They don't hear the patient if they have an accident or anything like that. They just see it on paper, the basics, the labs, the ulcer size, and see how the doctors would treat them. They do not know their insurance status, how much their insurance is covered, but let's just assume the best and that they're covered for everything and everything's at their disposal. It'll be very interesting to see something like that. That would be really fun. But today's episode is not just clinical, it's not just medical, it's about the system because behind every wound, there's a decision that is made or delayed. And also, I saw in the news there was this lady who got her leg amputated because of knee injury. I think she has some serious knee injury, and this is a young Black woman, and she sued the hospital. I believe she won the lawsuit. I think she got $18 million, but they the premises of her suing the hospital was that she had delayed care. So the time that she presented to the hospital to the time that they actually intervened, she lost her a lot of tissue oxygen or tissue vitals of that injury was lost during that time. And she's saying that they should have treated her with the standard of care, which was immediate attention, urgent care, and she should have gone to the OR. But, sometimes, like we said, delay costs a limb or even a life, unfortunately. And that's something that we have to address. That's why I said it has to do with the system. So, what is the uncomfortable truth? Let's say plainly, healthcare is not about medicine. Healthcare is about access. And access to healthcare is actually controlled by your insurance status, your income level, your geography, and the policy rules. And two patients can have the same ulcer, but completely different outcomes. And why is that? Because one has coverage and one has barriers. So, how does money actually shape patients' health decisions? Patients don't just ask, will this heal? Patients ask, can I afford this dressing? Will the insurance cover this visit? Do I go to work or do I go to the doctor? These are real case scenarios. So, let's say a patient with an early plantar ulcer, we recommended an offloading device, weekly visits, and advanced wound care. The patient response could possibly be, I can't miss work. That's not non-compliance. That's patient trying to survive the economics of the system and trying to make money, right? Insurance. When it comes to insurance, the insurance is pretty much the invisible hand of healthcare. So insurance doesn't pay for care. It decides what care is allowed, and that's what insurance does. Let's just be honest. And certain dressings require failure first, right? They need to have know that standard of care failed, and we have to document it, and that the insurance can cover advanced wound care therapy options. Advanced therapy sometimes need prior authorization, so the insurance is up to the insurance to approve the authorization or not. And then also a lot of insurances, there's limited number of visits approved, right? So in translation, a patient often can have to get worse before they qualify to get better, unfortunately. That's in some cases, okay? But they do need to show that, yeah, they're not responding to standard of care for so many weeks, right? Even I remember one time they denied my pre-auth for advanced imaging for MRI, and they were like, "Oh, the patient didn't do physical therapy yet, so the patient should do physical therapy for 4 to 6 weeks before we approve for the MRI." And I was like, "Oh, okay, okay." Even though this patient had this for like 2 years, and they're just coming to see me for the first time, but they had it for about 2 years. They were not doing well. It was painful. They did the ankle brace, they did everything. It's still painful. They need to do an MRI, but insurance won't cover it unless he did physical therapy and did not improve with physical therapy. So this is where it gets serious. Delays are caused by insurance approvals, financial limitations, transportation issues. And I think you remember my in episode with the amazing Dr. Hardiman. He's an amazing physician. He's just a wealth of knowledge, so I can't wait to have him back. But he was also talking about that. He was addressing that. And as we know, these delays in insurance approvals, financial limitations, and transportation issues can lead to an infection progressing, osteomyelitis, and gangrene. And that's some of the hardest things as a physician or a healthcare professional that care, knowing that these limitations exist. Like, I'll be like, oh, we need to get an MRI. And the patient's like, I can't afford that, and my insurance won't cover it. And I'm like, ho we have to treat it's hard to treat these things blindly, but you have to do the best that you can, right? But it's standard of care, you need an MRI. By the time sometimes patients get approved, the limb is no longer salvageable. I think I remember telling on this podcast my experience with insurance approval. They denied my patient's MRI, and they got an X-ray, and my patient took a while to get the X-ray, but I wanted X-ray and MRI. I knew I wanted an MRI because I did suspect osteo. He had a big black the unstageable ulcer, pressure ulcer along the heel, and they just got discharged from the hospital, like, literally a day ago, and they said, "Just follow up with podiatrist," and I was just like, "Oh, they discharged you like this?" And he's just like, "Yeah, but it's still very painful," and I was like, "Okay, did they do an X-ray at the hospital?" He's like, "No," because he was there for a completely different reason, but I was still confused why they didn't have podiatry on him during the whole visit because he said he was there for about a month, so I was very confused by that. But yeah, unstageable pressure ulcer along the heel, a scar along that area. It was a little boggy. I wanted X-ray right away. I told him get the X-ray today or tomorrow, but definitely get it today. But they came in around maybe 4 or 5 p.m., so it was really late. I was looking out for this X-ray, and literally, it took him, I think 3 or 4 days, or I don't even know, 5. I just remember he finally got the X-ray, and I also at the same time with the X-ray, I got the notification that they denied his MRI, and I had a peer-to-peer. A peer-to-peer is when they deny your request for the insurance to approve it, and the peer-to-peer is a physician, your physician, speaking to the physician of that insurance to explain why this needs to get approved, okay? And so I did the peer-to-peer, and when I looked up my patient's X-ray, because it seemed like he got the X-ray literally the same day of my peer-to-peer. But it was kinda weird, but the timing was perfect because his X-ray did not show up until the day of the peer-to-peer online, and when I pulled up his X-ray, it was gas. It was gas on it, and I'm just, like, calling him right away, telling him, "Go to the ER immediately, just tell them that you have gas, get an X-ray, tell them that you have gas," and he did. Finally, he did. And I remember a whole year later, he came to me and I didn't recognize him because when he came the first time the year before, he was very malnourished and very weak and he was wheelchair bound. And when I saw him a whole year later, he was very healthy and full and walking, and he came to me again because he had a little tiny baby ulcer on one of the toes, and he's like, "Do you remember me?" And I was like, "No." I was like, "No, I don't. I'm not the best with names," you know, and he's like, "You sent me to the ER because you said there was gas in my foot, and you kept on calling me because I think most of my patients will remember me from constantly contacting them to make sure that they're okay and to make sure that they get to the doctor or the ER or to the referral that I made sure because it's very important because people can get lost in translation. But he was just like, "Yeah, you saved my life." They told me that if I didn't come sooner, I would have lost my limb. And I was like, "Oh, wow, I'm super happy, you know?" But let's go back again. When I was doing a peer to peer and they were talking to me and they were telling me why they were denying the MRI, I just told them, I said, "I'm gonna send the patient has gas in the foot. The X-ray report says gas. Please look at the X-ray report. Says subcutaneous emphysema." And Yeah, the patient has gas, and they were like, "Oh, I'm so sorry, the MRI is approved." I was like, "It doesn't matter anymore. The patient's going to the ER." I was like, "It doesn't matter anymore." And they're like, "Oh, okay." But I was like, "Yeah, y'all coulda just approved it." But that's some things that doctors have to go through, patients have to go through, okay? Because like I said, by the time some patients get approved, it can no longer be salvageable. So that's a problem when it comes to the health insurance system and the invisible hand of insurance. Now we have to think also about the disparities, okay? Who is most affected by this? And it's not random, okay? Research consistently shows higher risk in low income populations, minority communities, rural areas, and underinsured or non-insured patient, and that's true. I even had the physician tell me that because everybody knows wound care is my thing. He was just like, "Oh, my demographic's not for you," because his demographic was in an affluent area, and he's like, "You already know the demographic." He's like, "My demographic doesn't really get wounds." I was like, "Okay," you know? He's like, "Yeah," he's like, "Your demographic is more," you know? I was like, "Oh." Thanks for telling me. That's a little rude, but it was rude to hear, but I mean, to be honest, he was telling the truth because the people who need the limb salvage the most, right, are patients who have had delayed healthcare. And that's the only reason why they got in that position in the first place. Delayed healthcare education, a lot of people are scared of the doctors. A lot of people are scared of the doctor bill. That's what most people are scared of, the doctor bill. And that's a pattern we have to break because I want people to be comfortable with access to healthcare, especially when it comes to limb salvage, way before you're about to lose it. Okay. Way before we get to that desperation point where we're realizing we might lose our foot. Okay. Because we have to remember less access to healthcare means later presentations, and later presentations mean worse outcome. Now, we have to also think about the psychology of financial stress. Money doesn't just affect the access, it affects the patient's behavior. Like I said, it causes a lot of stress on the patient. Patients even sometimes have PTSD from the doctor's bill. I've had a patient, she said that her doctor's bill was like 30K here, 30K there because she had vascular and amputation and needing a wound vac and the insurance, no insurance. Okay? But I'm so happy that they came whenever a new problem arose because she learned from that incident that delayed care can cause you your limb and cause more serious consequences like hospitalization. Okay. Also, when you're dealing with financial stress, you're more likely to ignore the symptoms. That's what one thing that we hear a lot as healthcare professionals, downplay the severity. A lot of people just downplay it because they can't feel it. Once they start feeling it, that's when. I even had another patient, let's say foreign body, they only came in when they started feeling the pain. This patient has neuropathy, okay? So that's something that we also notice because the neuropathy does mask the pain symptoms of an infection worsening until it gets too far. And that's when the patient is like, oh no, something is wrong. But you see that? They came in because they could feel the pain now. Because it gets really swollen, the nerves are going haywire, and the infection is progressing up to other areas where there is no the neuropathy isn't as strong and they actually can feel it. And then also patients avoid follow-up. Patients, when they get close to healing, they avoid follow-ups because of the money. And unfortunately, that's where the relapse happens, the recurrence, the wound getting worse happens. That's something very common. And you also have to think about the stress hormones like cortisol. Cortisol impairs wound healing, increases blood sugar, worsens inflammation. So money stress actually does slow healing. So we have to incorporate that and learn to subtract that from our wound healing equation to help the patient and the wound healing equation when it comes to limb preservation and amputation prevention. So, the irony of it, prevention costs less than actually curing, and we know that, okay? But I don't get it. I don't get it. Prevention cost is proper shoe gear, routine visit, and education. Amputation is surgery, hospital stay, rehab, prosthetics, and loss of income because you're not working during that time. So research insight is preventative care is far more cheaper than treating advanced complications. Yet preventative care seems to be the hardest thing to access for patients. So when our patients forced to choose. Real patients have to make decisions. Unfortunately, when it comes to finances, sometimes I have to think about the rent versus the medication. I even read in the newspaper a few months ago about a gentleman who chose to pay his rent over his life-saving medication and ended up passing away, unfortunately. And that is not a way of quality of life. That it should never be anybody's story. That should never be anybody's story. Choosing between shelter and health and life. No, okay? Food versus a clinic visit. Work shift versus wound care, okay? It's not non-compliance when a patient doesn't come up because of money. It's not non-compliance. It's being misunderstood. It's not that the patient doesn't care. It's that they can't afford the care the way we expect it to be, okay? It's mostly the healthcare system that's failing the patient, okay? Because let's be honest, the system failures in wound care, the system often reacts instead of preventing. So late referrals, okay? And we have to make patients understand the importance of these referrals. Follow up. I don't wanna hear your 3-month appointment after your 3-month follow-up appointment with me, and I say, "Oh, how did that referral go?" And they say, "Oh, I didn't follow up with them yet." I'm like, "You know better. You know me. I know you. You know that I didn't refer you to this doctor just on a whim. Your referral is important, and you need to follow up real quick, because if it was a referral for $1,000,000, I know you would have called that person the moment or even in the office. Okay, if it was a referral to get $1,000,000, I know that referral would have been called in a second, in a jiffy. Okay? Then you have to think about the fragmented care, limited podiatry access, and lack of education. We spend more time saving limbs than preventing the loss, unfortunately. So, what can be done? As providers, we can understand the financial barriers of patients. I know that way too well. I can honestly say that. Offer realistic care plans, prioritize education, and use cost effective options. For patients, speak up. Speak up about your financial limitations, okay? Don't let nobody say, oh, can't help you here. No, you can. Let's make a compromise. Let's figure it out, okay? And then, like we said, there's an episode on the transition of care. Like, let's say your doctor doesn't accept your insurance anymore or whatever. There is a transition of care process, okay? Seek early care. The earlier, the better, okay? Use community resources. Prioritize foot checks, okay? Prioritize this, okay? And for the system, expand. We need to expand preventative care coverage. We need to improve access to specialists. We need to reduce approval delays and invest in early intervention. And you know what? Here's the biggest message I can have for any diabetic patient. I promise you with this. If you're a diabetic patient and you have diabetes, yes, I am a podiatrist. Yes, I'm a wound care specialist. Yes, you need routine tests, right? But one thing I need you to have as your best friend, as a diabetic, your best friend should be your vascular. You can do no wrong having the vascular specialist as your best friend. Okay? You need to follow up with vascular at least once a year as a diabetic. Yeah, I don't care if you're not experiencing any symptoms. They will educate you of the progression of diabetes. What are the risk factors, things like that. But you need to make sure that your vascular status, every part of your body vascular status is good, because diabetes, when it presents in the foot for us as a podiatrist or limb salvage specialist or wound care professional, when it presents in the limb, it's already gone too far. It's usually secondary because of vascular compromise, okay? So y'all need to remember that when it starts presenting in the foot, it's already manifested earlier, okay? So you have to keep that in mind, as well as the biomechanics. But us as podiatrists, me as a podiatrist, like I said, as a wound care specialist, we're skin gardening. Skin gardening. And I think the vascular is the sun and the rain. Okay? The vascular is the sun and the rain. We need the sun, we need the water, and that's what vascular does. There's no way a plant can grow without the sun and the water, right? So that's what we need. You need to have vascular as your best friend. Okay? So, big message today is money should never decide whether you could keep your limb or not. Okay, absolutely not. Who heals? Money should never decide who heals and who gets care. Because right now, unfortunately, it does. But we have to remember you got to advocate for yourself. patients. That's what we're here for as physicians. We did not get into this healthcare profession. I know I didn't, not for the money, but to help people and change lives and make people's quality of life better. So behind every wound, there is a story, and that's why it's also good to hear patient stories because when they present to a healthcare professional or wound care specialist, ask them, "How did you get this wound? What happened?" You know? And you'll be surprised. I get it. Everybody wants to be independent, but a lot of people do try to do it themselves to avoid the cost of healthcare, and it ends up costing more. Okay? And I hope you remember that because every person deserves access to quality, high quality healthcare. And this is Dr. G, because wounds don't just form from pressure, wounds form from poverty, delay, and denial. Okay. And if the insurance doesn't cover your care, it can control your timing of survival. So you have to remember that be an advocate for yourself. We're here for you. Just contact us, okay? Even contact Diabetic Foot Files if you have any questions. We got a whole list of referrals of people, okay? And this is Diabetic Foot Files, and take care of your feet because they take care of you.